classes do you have today?
4.
I only have one.
You have one?
Finally, just you. Before they end up killing me the rest of the week.
But you're coming back to the 2 p.m. class with us, right? I'm totally just kidding.
Okay. At this point of the week, and consider the schedule at okay, guys. Ketones, antifolate drugs, other drugs, these all are mainly inhibitors of that DNA synthesis or that nucleic acid synthesis. That's mainly what they are. If I turn this on, it's going to be easier. So, all these type of different drugs are going to be nucleic acid synthesis inhibitors. They're going to be trying to avoid that replication of the bacterial genome. So we're going to have 2 different types. One that's going to be acting indirectly to avoid that replication of the genome, and other that's going to be directly affecting that genome. For those that are indirect, there are going to be those of folic acid synthesis inhibitors, the antifolate drugs, which are going to be mainly the example of those sulfas. Which sulfa do you know? Sulfamethoxazole, sulfonamides. Those are direct acting, are going to avoid the replication or the transcription. You're going to inhibit this section. Those ones are going to be known of direct nucleic acid inhibitors, and these are all the ketones and other drugs. They're synthetic, they're created in a lab, they are not depending on other organisms to create the drugs. They're going to be replicating that DNA or metabolism, the antifolates. The majority of them are used for urinary tract infections, but there are also some used for GI tract infections. And we're going to go the main one used. Sulfonamides, trimethoprim, and fluoroquinolones. Trimethoprim, you know, it's usually given together with a sulfur. So, from those ketones, they're going to be affecting that nucleic acid synthesis. Those ones, we've got 2 main. There's going to be ciprofloxacin and dalofloxacin. The 2 main. We've got other 2, moxifloxacin, you also know it as Adlox on the market, and gemfloxacin. They're going to be inhibiting mainly that DNA gyrase. They're going to be affecting 2 types of topoisomerases. Now, the 2 that's going to be affecting all of those gram-negative microorganisms, topoisomerase 4, that's going to be affecting gram-positive. They are mainly bactericidal. They're going to be killing the microorganisms. But you need to avoid the intake with antacids. Which other drug was necessary to avoid those antacids? Tetracyclines. Good. Resistance. The microorganism is going to start mutating, changing its DNA sequence to avoid, they're going to be changing specifically the structure of that topoisomerase to avoid the antibiotic, to avoid the drug to go there and block it. Those changes, those mutations are going to be plasmid mediated. So that plasmid is going to be saying, uh-oh, something's going wrong. I need to tell the new generation that this drug is bad for us, so we need to avoid it and find a way to avoid it. So they start mutating. Clinical use. These 2 they're both going to be mainly gram-negative rods in the urinary tract infections, gastrointestinal infections, including Pseudomonas. It's effective, or at least at some point of its history, it's effective against Pseudomonas. Some gram-positive, especially where on external ear infection, otitis external, and some Shigella infections. Depending on the severity of those Shigella infections, those Shigella diarrheas. It's contraindicated on pregnant patients and nursing patients as well. Teratogenic, and it's also going to be cleared through that breast milk. Kids under 18 years old and the pregnant patient, the fetus is going to also be affected by this. There may be that cartilage damage because it's going to be affecting that chondrogenesis, so they're not going to have a proper growth. They're going to be on the pregnant patient, the fetus is going to be having those malformations on their growth. And what's the patient going to be complaining that you need to make them aware that they may present symptoms? The GI that's going to be upset. They're going to be complaining of either nausea, vomiting, slight diarrheas, superinfections. And with superinfection, it's more likely for those patients, elderly patients, that you're giving this antibiotics, you're going to get rid of the majority of the microorganisms, so they're going to start having the overgrowth of Clostridium difficile. Skin rashes, it also may induce allergies, headaches, dizziness, and this is just some because some patients may also present with confusion. They may present with seizures. It passes easily through that blood-brain barrier. And this side effects, the leg, the cramping, the myalgias, those prolongation of the QT interval, tendonitis, and tendon rupture on patients over 60 years old, it's more frequent with levofloxacin, not with Cipro. Antifolets. We've got two main. Sulfonamides, that's going to be that silver sulfadiazine and sulfacetamide, and those that are going to be folate reductase inhibitors. Trimethoprim and a combination of trimethoprim with sulfonamide, sulfamethoxazole. Very frequently used. So the sulfonamides are going to be inhibiting the DHF, which is going to be present on bacteria and parasites. So this is one medication that's also going to be used not only for the bacteria, but also for those parasitic infections, especially skin. The folate reductases, they're going to be blocking that DHF and also the THF. So they're going to be avoiding that formation of this tetrahydrofolate, which means that they're not going to be allowing that new genome to get the nutrients, to get those folates that he needs to get those amino acids to start inducing all that formation for that genome chain. This one was some of the first drugs that were used for systemic bacterial infections, so it was very commonly used, very frequently. They were starting creating all those microorganisms, the resistance, but since they were presenting the resistance, we stopped using it, just like penicillins. So nowadays, again, it's trying to be effective. Penicillins are, once again, we're going back to the past, so it's happening with the sulfonamide. So now they're going to be effective. It's easy to be giving those, especially that combination of trimethoprim and sulfamethoxazole. This one, the sulfonamides, they're broad-spectrum bacteriostatics. The other ones are bactericidals. So if you're giving the combination, you're making sure that you're getting rid of all those microorganisms. Most commonly used urinary tract infections, especially on kids, that combination of trimethoprim and sulfamethoxazole. So, prostatic infections, pulmonary infections, especially due to pneumocystis hirovecii, formerly known as pneumocystis carini. Those HIV patients are the most frequently to be presenting with this type of pneumonias. Nocardia species infections. Patients that have those burn injuries, it's also going to be effective. Ocular infections, especially due to trichomonas. So it's going to be frequent on those kids that are having that infection through that birth canal. But they may induce skin rashes, especially severe consequences with the Stevens-Johnson syndrome. Do you know what's the Stevens-Johnson syndrome? Yes or no? Raise your hand if you do know it. I've heard of it.
Heard of it.
Okay.
Yes, sir.
You've heard of it, but you have no idea what it is. It might be so cool and nice and frequent because it's mentioned a lot, especially with a lot of medications. Stevens-Johnson syndrome is a patient that's having a severe manifestation of like an allergy in which they're going to start shedding their skin. There are patients that appear to have this massive burn of the entire organism. They start detaching that superficial layer of the skin. Good thing for them, they're going to get brand new baby skin. Bad thing, they're at higher risk of those opportunistic infections while they are shedding all that skin because if they're getting in like an intoxication due to the medication. Trimethoprim with sulfa is one of the most frequent ones to cause this on some patients, especially immunocompromised patients, or at higher risk. They are telling you, well, I'm allergic to everything. Those that have those atopic dermatitis, all of those that already have a history of some type of allergy, they're at higher risk. It may also induce erythema multiforme, GI distress, nausea, vomiting, diarrheas, headaches, those sensible patients, hepatitis, hazards, absorption through the liver, so that, yes, they may start presenting with elevation of those hepatic enzymes. But once you're done with the antibiotic, everything's good. So you need to be careful to give it on those patients that already have an hepatic condition. It may also alter that hematopoietic system. It's toxic. So it needs to be given cautiously and a strict schedule and under strict days recommended, depending on the infection. These other are also going to be affecting directly to that nucleic acid synthesis. The majority, especially nitrofurantoid and daptomycin, are given of those urinary tract infections, while Mixin B is more frequently used on those ophthalmic eye drops in combination with neomycin. Rifaximin and phytomoxin is not that frequent, and some other that you can also include here is going to be metronidazole. It also has that function of altering that nucleic acid synthesis. So daptomycin, it has a lipopeptide that's going to be altering on those membrane channels of the bacterial cell. So there's going to be this disruption of that cell, besides altering those genomes. Especially effective against gram-positive cocci. And they're going to be more frequently used on those Staphylococcus aureus infections, especially on patients that have undergone some type of surgery, or patients that are diabetic and already had that progression, burn patients, effective against those multi-resistant staphylococcal strains. Also effective on patients with bacteremia. It has also the patients with meningitis. It's easy to have all that flux and circulation. Patients with endocarditis, especially of the right side. There's some specific microorganisms that love to stay there, but I'm not going to tell you now because then I'm going to stay with nothing when we see endocarditis. And some strains of vancomycin-resistant E. coli, and some resistant enterococcus. It's not useful for pneumonia. We know that we've got special substances there in order for those lungs to be functioning properly and doing all their expansion, but those substances are going to inactivate the drug. So it's not going to be useful on those patients with pneumonia. It has muscle toxicity, so it's likely that the patient may end up with some type of myopathy or even rhabdomyolysis. If a patient presents with rhabdomyolysis, what are going to be complications? What's the risk of them having that destruction of the muscle? You already passed through a musculoskeletal block. Just get it out of the archive of bad subconscious. Why is it relevant? Why that risk? What's going to happen to the patient if that poor muscle starts dying?
It could block a vein. The tissue could end up blocking a vein. Then you get ischemia.
Yeah, it could start blocking, but there's something more severe than that. Okay, let's put it in an easier way that you're going to remember. What happened to Dr. House?
Neuropathy. Feeling of pain.
That was one consequence of it. What led to that?
The muscle dies and you can't use it anymore. You can't walk, you can't
Besides,
move.
when on that acute moment in which the muscle is dying, what's happening?
Regrowth, and then there's going to be a tumor.
No. No. What happens on inflammation?
Swelling.
The white blood,
Rubor.
immune system.
And what enzymes and what substances are starting to be released?
Myoglobin
Myoglobin, and what's happening with that myoglobin?
ends up being filtered and it can kill the kidneys. It can block
It
the
may
kidneys
start
and-
shutting down the entire system, and the patient's going to end up with a multi-organ failure. Because of that, the muscle is dying, it's releasing that myoglobin, it's releasing other toxins like something that starts with an L, with that lactic acid, so it's having that massive inflammation. It's easy to start having all those little teeny tiny substances that apparently won't do anything, but they're going to kill the patient because they're not easy to filtrate through those poor kidneys, so the patient goes down. So we need to be careful, especially in those patients that are the elderly, that are likely to be presenting with this type of complications, and also those that are also already at high risk of having some renal dysfunction. Make sure to avoid and prevent. Nitrofurantoid, bactericidal against gram-positive and gram-negative, highly used on urinary tract infections. Especially lower urinary tract infections. Which is the lower urinary tract? Bladder. What other section? Urethra. So we're going to have the bladder and the urethra done. Kidneys and ureters are going to be the upper urinary tract. So they're going to be more likely to be effective against E. coli, especially uropathogenic E. coli that loves to do all those urinary tract infections. Enterococcus faecalis, Klebsiella pneumoniae, Streptococcus apophyticus, Staphylococcus apophyticus, which is going to be more likely to be part of that normal flora of the GI tract and the vaginal canal and the urethra. They're part of that normal flora. But once the immune system is a little bit down, they're going to start doing their overgrowth. But it's not going to be useful for Brittos, which is another microorganism, part of the normal flora of the female tract, Serratia and Pseudomonas aeruginosa. Side effects. Again, nausea, vomiting, diarrheas, especially on those more sensitive patients. Pulmonary fibrosis, not that frequent. Hepatitis, hematological toxicity. We get in those patients at higher risk. It has that clearance. It's going to be metabolized on the liver. Polymyxin B. Bactericidal as well. Have you noticed that we don't have very much bacteriostatics? We have just a little handful of bacteriostatics. This one's going to be affecting the polypeptides that's going to be interacting with all those phospholipids on that genome. So that cell membranes. So it's going to start making little holes on that cell membrane, so it's going to start leaking. It won't be able to contain all the organelles of that bacteria. It's going to start doing all that damage. It's mainly used, like I told you previously, skin and ocular infections combined with that neomycin. Effective against those gram-negative rods, and it's also going to be effective combined. You've seen also those combinations with 3 antibiotics on those eye drops, and the Neosporin has 3 different antibiotics. Even though it's an ointment, in theory it should be given with a prescription, but you can get it over the counter and you can just get, oh, I want this. And this other presentation, and the spray, and everything. So it's usually going to be given on combination in order to get that synergistic effect. But there is a version of the polymyxin used in the hospitals for those IVs in which it has to be highly given with care on those patients at higher risk of renal failure. It has a renal clearance. It's not going to be effective also, again, for those species. It's not useful for them. Rifamycin, bactericidal, gram-positives, gram-negatives, also another broad spectrum. Clinical use mainly on those travelers' diarrheas of patients over 12 years old. Otherwise, they're at higher risk of presenting some side effects that you're still not sure which they are because they're very random. Patients with hepatic encephalopathy. There are also patients that are already immunocompromised. There are patients also with that irritable bowel syndrome that's more likely to be allowing that local immune system to be down, so the normal balance of that microflora is going to be altered. So it's going to be effective against those specific strains of E. coli. Enterotoxigenic enterobregative, which is going to give us diarrheas, but without blood. Enterococcus fecalis, Klebsiella pneumonia, and also Staphylococcus. Side effects. Since it's not that frequently used, they don't know which are the side effects. It's not commonly used. It's usually already used on those immunocompromised patients. They already have other infections, so they don't know, they cannot tell, okay, is it all the other comorbidities that a patient is presenting, or is it the antibiotic causing the symptoms of the patient? So it's still like limbo. Fidaxomib. This one, effective against Clostridium difficile. It's going to inhibit all those RNA polymerase, so that's going to be the RNA synthesis that's going to be altering that nucleic acid. that bacterial genome. Also, no idea which are going to be the side effects, because the patients that are going to be treated with this and have to assume diffuse overgrowth, they're already presenting with membranous colitis, they're already having toxins of this bacillus circulating due to the spores. So, again, they cannot evaluate because they already have a huge amount of symptoms. So they still don't know which are the ones that are going to be specifically of fidaxomicin. Doubts or questions? They didn't change the schedules. The majority of my classes on Pharm are 1 hour or less. Because the first semester that I gave this was last semester to help Dr. Garcia avoid from going flatline here. So I managed to reduce his classes that have a little bit of information, just a little bit, onto high yield, onto all that high yield of medications that you're going to be asked on your staff, and the most frequently used and recommended by the CDC. That's why it's shrunk to 1 hour or a little bit less. Okay? Doubts or questions? Yes, no. I'll try to put them on antimicrobacterial drugs over those charts. You saw the charts on the yesterday? Yes or no? I add by every single aminoglycosides the chart of those drugs and their side, where they were going to be affecting, if they were on the P side or the A side of the ribosome, their mechanism of action, their consequences, all clearance. I added those charts. I'm going to ask questions for those charts. Yeah, no, I don't think so. I'm not that cruel on block 6. I have other 4 blocks in which I can enjoy the questions.
Are you going to do the next one now or after?
Mycobacterial?
No, because I need to scan the charts. I want to try to make sure that they're already on the slides, which obviously they're not on the ones that are right now on mine.
So we're done until Zavala's class?
Yeah.
Okay.
You can go get that precious coffee. We only have 2 mycobacteria. Which are they? And you're going to know them because you've heard of them. We only have 2 mycobacteria. Mycobacterium tuberculosis and, well, the most frequent, lepra. Aegium is going to also give us those respiratory infections, but it's not as evil Knievel as lepra and tuberculosis. So, the main ones, the most frequent ones that are going to be affecting the system, especially going to be Mycobacterium tuberculosis. On those patients that are immunocompromised are going to be more likely to be affected in the United States. Mycobacterium lepra, especially in Texas and all those southern states that have armadillo. So we're going to have 4 main, and from all this different antimicrobacterium, they're going to be attacking different microorganisms, different strains of those mycobacteria. For Mycobacterium tuberculosis, we're going to have mainly isomycin, which is going to decrease the synthesis of that mycolic acid that's present on the walls of that bacterial cell wall. Monotherapy. It can be used as prophylaxis and it may be used on patients with latent TB. That means if you've had the infection once upon a time, there may be a reactivation of one of those capsules of those granulomas of the lungs. Okay? Side effects? Liver affection. It's going to have that metabolism on the liver, especially they're going to be inhibiting that P450 inhibition, which is also going to give us more consequences of that the toxicity. It may induce vitamin B6 deficiency, and there are mutations they're going to be decreasing that CAT-G expression, so the isoniazid is not going to be able to be attaching to those cells in order to start doing that disruption. Okay? Ethambutol is going to decrease the polymerization of that carbohydrate. Again, it's going to be affecting the cell wall. Sorry guys, but majority voted. 10 minutes and that's it. Really fast. It's less than 10 minutes.
Just sit down.
Okay, ethambutol. So this one's going to have side effects on that optic nerve. So the patient's going to have the color blindness. Rifampin is also used besides in TB, also in lepra. It's going to inhibit the DNA-dependent polymerases, mainly on the meningococcal prophylaxis. Also helpful on influenza B. Okay? Again, the resistance is going to be due to mutations on those enzymes. Pyrazinamide, not very frequently used, but it has a very fast killing rate of those microorganisms. It's going to inhibit the bacterial growth by inhibiting this fatty acid synthesis. So it's going to be affecting all that formation of the bacteria cell. They're all first line, and usually they're going to be giving 2. Amikacin, second option. If neither of these was working against TB, then they're going to give amikacin. Avium and intracellular infections, azithromycin. We've already seen this in other antibiotics, part of other that have all different mechanisms of action, but they may be effective against mycobacteria. So, we already saw it, you already know it. For lepra, it's just going to be inhibiting that folate synthesis. So, it's going to be effective on both versions of both types of Mycobacterium lepra, which is going to be what you already know as leprosy and the tuberculous form. I'm not going to go deeper because we're going to see that on block 10. Okay? It may induce hemolysis on the blood. Okay? Rifampin is also effective against Mycobacterium lepra, and clofazimine is going to be bacteriostatic, but it may induce a lot of other symptoms on the patient. The majority of the antibiotics, if you consider, they're going to induce that nausea, that vomiting, in some cases mild diarrhea. They are attacking the entire normal microbiota of the organism. You've heard about this one, thalidomide. Very frequently used on the 60s and the 70s, induced a lot of teratogenic effects, a lot of malformations on the fetus of the product. So it started decreasing its use, and it got more regulated when they could be using thalidomide. So it's going to be immunomodulating the entire system. That's why it's going to be affecting the product. That's why it's highly teratogenic. So never ever again was given to women, those pregnant patients. Told you. I told you it was a really fast. That's why I wanted to add in the charts. I will still add the charts and change the PDF that's on Moodle with the new one with the charts. Questions or doubts? The majority of them, we already saw them. You already knew them. In theory. At least you now can say that you heard about them. Hey.
Hey guys,
It's fine.
2 quick little things. First, Zabala is going to be here, so she's going to give her class earlier, so you guys can have a long lunch break. And second thing, I just talked to DHC professors. There will be DHC Monday. They said later today they're going to email out the group numbers, and they're going to put up on Moodle the information. So usually if you're in group A or the first part, keep an eye out because you'll probably be having DHC Monday.
No, that's
And
not
it's
true.
Friday.
The numbers are all over the place. Like I was always in the last one, and I'm closer to like number 4.
Well, just keep an eye out for those emails and they'll let you know your group numbers.
Yeah, your group numbers are all over the place, guys. It's not the ABC thing anymore.
They made eeny, meeny, miny, moe.
Sort of.
Look on the bright side. You're gonna get to know more about your classmates from the lower section of the list or the upper section of the list or the middle section.
Me habían dicho que ya tenemos un grupo, ya tienen
We should
nombre
ask
ya.
her if she could be added to our group.
Pensó que la metería era subidos. Y le digo, oye, vamos a subirlo ya correo. Ah.
Oh, right. Yeah.
Pues, je voudrais que...
What was that, Jay?